Thanks a lot, Dr. Rakesh, for the kind words of introduction and providing with this opportunity to interact about this very, very important topic that we are going to deal today with regards to the vitamin D and its effect in this time. This is going to be more of an interactive discussion about how vitamin D plays an important role in our health and disease, and how we can improve our outcome, and how challenges have been put forward by this pandemic that we are all faced with, the COVID-19, and how we can go forward on that. You can view many more presentations and learning aspects in our website, which is learning.growsociety.in, wherein a lot of these interactive videos are available, as well as we've got information which is there with regards to the various aspects that we'll be discussing today as well. Now, what we have seen is that there has been a significant change in terms of our lifestyles and so many things which have happened in the last few days. Vitamin D is something which is really, we'll think that what is vitamin D got to do with COVID-19? But definitely we need to understand that as COVID-19 has changed a lot of things, vitamin D is something which may be one thing which we have to also think of in terms of improving our lifestyle and various other factors. So we are all aware that how this simple, very small virus has changed the entire world, has resulted in a massive amount of over 1 million people being infected across the world, with a significant mortality that we are seeing. We are going through a phase which none of us expected ever, and we are faced with a lockdown for we don't know how many days. To go forward, it has changed the way we perceive things, the change the way we live, and definitely it is going to impact a lot on many of those factors. And today I'm going to focus on one very important factor as to how vitamin D will be affected by that, whether vitamin D effects can have a cascading effect with regards to this condition, and how we can improve on that regard. So we'll start off with the very basics with regards to vitamin D. And we all know that vitamin D is basically a product of cholesterol. It is basically a steroid, and there are two forms of vitamin D which are there: cholecalciferol and ergocalciferol. Now, cholecalciferol is what is basically obtained from the animal sources, or what the humans produce themselves, and ergocalciferol are what we get from the plant sources. The only difference is that there's a double bond that you can see out there, which is highlighted in ergocalciferol, which is not in cholecalciferol. Conventionally, there is not much difference between the two, with the exception that the debinding capacity is different. The binding to the debinding protein may be different, and therefore the efficacy may be slightly different. So while cholecalciferol has a greater tendency to bind to the debinding protein, which is basically taking these molecules across the different parts, for ergocalciferol, this binding capacity is low. Therefore, the rise of level tends to be slightly higher for cholecalciferol as compared to ergocalciferol. But when we talk about a vitamin D overall, or we talk about vitamin D estimation, we are basically talking about a combination of both cholecalciferol and ergocalciferol in this perspective. Now, the dietary sources of vitamin D are extremely limited, not giving more than 10% or so of our entire vitamin D. It is there in certain animal sources: salmon, cod, and mushroom, and it is in the form of cholecalciferol, as we discussed. Now, plant forms can be in some of these vegetables and yeast which are there. And very interestingly, why do plants actually have vitamin D? Now, vitamin D is a compound which increases the growth of roots. So in areas where there is more sunlight, there would be a greater amount of vitamin D produced, and the roots will go deeper and they will be able to get their water more. So there is an evolutionary advantage of producing vitamin D in temperate places. So therefore, these plants will have some vitamin D there, which is in the form of ergocalciferol. Both of them are collectively named as vitamin D. Now, both of them have a similar biological effect, but as discussed earlier, there is a slightly higher rise in vitamin D level with cholecalciferol as against ergocalciferol. Now, vitamin D is basically synthesized also in our body, which is a direct product to the 7-dehydrocholesterol, which is also the precursor of the entire steroid pathway. The cortisol, the aldosterone, the progesterone, the estradiol, they are all formed from this precursor molecule. So from this 7-dehydrocholesterol, based upon the exposure to sunlight, and particularly the UV rays at 290 to 315 nanometers, there is a conversion of 7-DHC to cholecalciferol, which is actually the form that we discussed comes from the animals. Now, this cholecalciferol is also converted to lumisterol if the sunlight exposure is too much. So body has got a foolproof mechanism of avoiding toxicity of vitamin D. If you get too much sunlight, you will get more inactive form of lumisterol, and cholecalciferol will be less in that perspective. And this limits the effect of sunlight exposure. Now, the amount of vitamin D produced will depend upon the skin color. So for a typical white Caucasian individual, a 10 to 12-minute exposure may be enough to produce around 10,000 international units of vitamin D. For colored individuals and for Indian people as well, the time required may be 3 to 10 times more. So we would require probably 30 to 120 minutes for sunlight exposure to provide the same amount of vitamin D, because our skin is adapted to avoid unnecessary exposure to sunlight and UV rays. If you think of it, there is a nice balance which is going ahead with regards to the UV rays exposure and vitamin D and folate. If you have too little UV exposure, you will have vitamin D deficiency. If you have too much UV exposure, you will have decrease in folate, causing cancers, melanomas, and skin. So the balance is achieved based upon the amount of sunlight you get, and the skin color is largely determined based upon that latitude aspect. Now, it is not only the skin color, but what angle does the light actually puts on the skin becomes important. As we go higher in the altitude, the production of vitamin D will come down. It is also affected by seasons. So we have the lowest production during winter seasons and highest production during summer season. There is also an effect, of course, if you are blocking the UV light using sunscreen, using clothing, or cultural issues that are there in that perspective. And of course, time is very, very important. Exposure between 10 a.m. to 3 p.m. is the ideal time to produce a reasonable amount of vitamin D. So if we really want to have a natural source of vitamin D, stand in the sunlight between 30 to 120 minutes between 10 a.m. to 3 p.m., which is not possible in most of our times. And when we talk about lockdown, of course, this is something which is going to be nearly impossible. And that's why it's not difficult to understand as to why we as Indians have a high predisposition to develop vitamin D deficiency, which is so commonly encountered. Now, once we get this vitamin D, which is absorbed by the intestine and it comes out, and since it's a fat-soluble molecule, it is taken by the chylomicrons. So it's basically the lymphatic channel which absorbs the vitamin D. This vitamin D is then bound to a D-binding protein because it's a steroid. It cannot really go through the blood. It has to be bound to a binding protein, and this binding protein will then take it from the intestine, from where the chylomicron is there, or from the skin, and it will basically take it to the liver. And once we take it to the liver, there is an action. The first metabolically important action which happens is at the level of liver. And this is basically at the level of 25-hydroxylase, which converts this vitamin D into a 25-hydroxy vitamin D. Now, this 25-hydroxy vitamin D is not a very potent molecule. It has got 10% the functional capacity to act on the vitamin D receptor if we compare it to, let's say, calcitriol, the most active form. But this is the best marker of nutritional vitamin D status. The reason for that is that the 25-hydroxylase enzyme is a unique enzyme which is not inhibited by its product. So if your 25-hydroxy vitamin D levels go up, it will not inhibit this 25-hydroxylase. Therefore, the levels of 25-hydroxy vitamin D would be a direct indicator of the vitamin D status of a given individual. The more you have vitamin D, the more you will have 25-hydroxy vitamin D. This, along with the fact that it is PTH independent and has a long half-life, makes 25-OHD the best marker for nutritional vitamin D status. This is something which we need to, and we'll be discussing a bit later as well. Now, this 25-hydroxy vitamin D is again bound to the D-binding protein, the same protein, and is then taken to the kidneys where the next action happens. Now, the major action of 25-hydroxylase is the hepatic CYP2R1 gene, which controls this. And we need to remember that liver has got huge amounts of 25-hydroxylase. So liver disease will not cause rickets unless and until there is a massive hepatic involvement. So there will be like 99% destruction then probably this activity will be less. You will have less 25-hydroxy vitamin D, and liver disease will not cause rickets unless there is a severe damage like this. What is also important to understand that if you have an individual who comes to you with a liver disease and rickets, think of alternate explanations of rickets. Maybe there is malabsorption, or maybe the cause of rickets is the cause of liver disease as well. So it may be cystinosis, Wilson's disease, tyrosinemia. But the big message out here is that a typical patient with chronic liver disease has got huge amount of 25-hydroxy still remaining. It will not cause rickets because of that, unless there are other factors which are there. Now, as discussed, there is a huge reservoir, so only advanced liver disease will cause rickets. Very importantly, just to reiterate, this 25-hydroxylase is not regulated by the PTH or 25-hydroxy vitamin D levels. It has a long half-life, it's a stable compound, and it becomes the best marker of vitamin D deficiency in this perspective. Now, once we have got this 25-hydroxy vitamin D, which is 10% the potency of the most active form, it has to be then activated by the kidneys. So basically, it is taken via the debinding protein and 25-hydroxy vitamin D to the glomeruli, where it is filtered. Now, we need to remember that 99.96% of vitamin D is bound to the debinding protein and only 0.04% is free. Now, this 25-hydroxy vitamin D is then absorbed, or let's say transferred at the level of the proximal convoluted tubule via a protein system known as megalin, which takes it into the PCT, where there is the 1-alpha hydroxylase, which converts this 25-hydroxy vitamin D to 1,25-dihydroxy vitamin D, which is the active form of vitamin D, which acts on the vitamin D receptor to result in various actions of vitamin D, which we'll discuss subsequently. So this 1-alpha hydroxylase is regulated via a number of endocrine factors, particularly PTH, which is a major regulator. So when calcium levels go down, PTH levels will go up. This 1-alpha hydroxylase level will go up and calcitriol will go up. So a lot of people ask as to why don't we measure calcitriol as a marker of vitamin D status when it is actually the actual vitamin D which is working. The reason for that is that it is PTH dependent, and the activity of 1-alpha hydroxylase also depends upon calcitriol. Lower the calcitriol in the body, you will have more 1-alpha hydroxylase, resulting in increased level. So the levels of calcitriol may actually be low, normal, or high in the setting of vitamin D deficiency, and therefore calcitriol is a waste of money if you want to evaluate somebody for a vitamin D status. If you really want to do calcitriol, do it in very specific situations like looking into vitamin D dependent rickets, looking into hypophosphatemic rickets, but not in a routine evaluation at all. And this is something which is extremely important to understand from that perspective. Now, this calcitriol is also bound to the debinding protein, but the binding is quite less. It is 10 times less as compared to vitamin D. So in a way, what you need to understand that if a compound is not binding to the debinding protein, it will have a sudden rise in the level, and then it will go off from the kidney and excrete it. So calcitriol and the analogs of vitamin D, that is 1-alpha hydroxylase and 1,25-dihydroxylase vitamin D, both of them have a shorter half-life, are acutely acting, and therefore they are very, very helpful in treatment of acute hypocalcemia, but they are going to cause a havoc if you treat them for vitamin D deficiency, because they are not going to be there in the circulation, they're not going to be deposited in the fat. So if you want to really correct vitamin D deficiency, you actually need vitamin D, cholecalciferol, or ergocalciferol. Calcitriol or 1-alpha vitamin D has got only role in acute correction of hypocalcemia. So this is something which is extremely important to remember. Do not treat a routine patient of rickets with calcitriol. Your fingers will be burned because that will cause hypercalcemia and nephrocalcinosis. We all talk about a wide therapeutic window as far as vitamin D is concerned. But remember that window is for vitamin D because it has got a big, only 0.04% is free. So very little acute effect will happen. If you talk about calcitriol, the window of opportunity or the therapeutic window is not wide. So be careful when you're using calcitriol in that setting. So just to summarize, vitamin D is produced via the 7-dehydrocholesterol under the influence of UV light as cholecalciferol. You can get it from the plant sources. Through ergocalciferol, this is then activated by liver to 25 hydroxyvitamin D, and then via kidneys to 125 dihydroxyvitamin D or calcitriol. Now, this 25 hydrocalcitriol will then act on the vitamin D receptor, particularly in three regions. The main effect is at the level of the intestine to cause increased calcium absorption, at the level of the kidneys to cause increased calcium resorption, and at the level of bones to cause bone formation. But the major role as far as the calcemic role of this calcitriol is concerned is to provide calcium in the blood. You may have somebody who has got zero amount of vitamin D, or the vitamin D is not working. And if you ensure that their serum calcium levels remain normal via IV infusion, rickets will not happen. So the major calcemic role of calcitriol is actually to build up the calcium level in the body. Now, body has got a number of homeostatic mechanisms so to take over this process. So if 25 hydroxy level is basically elevated, there will be effects on the calcium and phosphorus absorption. There will be more calcium and phosphorus coming to the body from the gut. In the absence of vitamin D, only 25% of calcium is absorbed. If you have enough vitamin D, it becomes 40%. So there is a 1.5 time increase with vitamin D which happens. It increases the calcium resorption from the kidneys, and it causes also bone formation. Now, why do we say that there is a big therapeutic window which is there in terms of vitamin D? Is that if your 25 hydroxy vitamin D levels go really high, there is another mechanism which will inactivate it into 24-25 dihydroxy vitamin D, and this will prevent the excess of vitamin D. Now, this is extremely important in that if you give too high doses, it gets inactivated. On the other hand, if somebody is on some medications which stimulates this inactivating enzyme, the 24-hydroxylase, phenytoin, phenobarbital, or anti-epileptic drugs or anti-tubercular drugs, this vitamin D levels may come down. So there is a very tight regulation in which 25-hydroxy vitamin D is either activated into calcitriol or inactivated into 24-25 dihydroxy vitamin D. And this is important from this clinical perspective. Now, just to summarize, basically the calcium phosphorus absorption through the intestine is largely regulated via the calcitriol, which we can see in this perspective. The calcium phosphorus deposition in the bone is also increased by that. And at the level of the kidney, it causes a decrease in calcium excretion while increasing phosphorus excretion. So the net effect of calcitriol is to cause increased calcium and phosphorus, its mineralization, and taking off the excess phosphorus from the kidneys in that situation. Now, this has been a lot of discussion with regards to the mainly calcemic effect, but we also need to understand that there are many non-calcemic effects of vitamin D which happens. If we look at the tissues which express 125 hydroxylase enzyme and the vitamin D receptor, we will find that beyond the bone, these receptors and enzyme systems are expressed in the macrophages, a number of immune cells, in the heart, in the skin, in the lipid system, as well as many of these cancer cells. And that basically means that there are local effects of vitamin D which are also there. We have been talking a lot about the endocrine effects of vitamin D, but the paracrine effects are very, very important, particularly with regards to immune modulation. And this may hold a key with regards to what we're discussing today as to how vitamin D can potentially be one of the players overall in terms of COVID-19. Of course, a lot of the non-calcemic benefits are association studies, but we cannot tell that they are causative in that nature. So we cannot directly link it to diabetes, dyslipidemia, to hair growth, skin problems, to cancer surveillance, or to immune modulation. But there are increasing evidence with regards to type 1 diabetes, with regards to bronchial asthma, that probably this association is significant. So if you forget about all these non-calcemic benefits, remember two things. Bone, definitely calcium, the major role is vitamin D. And for infants, a big role of vitamin D on the cardiac contractility. The major cause of neonatal or infantile cardiomyopathy is vitamin D deficiency. And if we correct vitamin D, we will be able to save a number of these newborns who have the sick picture. So we'll be focusing on a lot of these things, and immune modulation would be something which is important from a clinical perspective. So if there is vitamin D deficiency, we will of course get rickets, delayed milestone. There could be possibility of recurrent infection and autoimmunity, cardiomyopathy, hair loss, metabolic syndrome, which will be there. So now we've discussed a lot about pathophysiology. We'll now go into more nitty-gritties and practical aspects which are relevant from that perspective. So why do we need to really bother about that? So we all discussed that to have enough vitamin D, we at India require 30 minutes to 120-minute exposure between 10 a.m. to 3 p.m., which nobody is getting. And during lockdowns, I'm sure it is really impossible to get in that perspective. And that's why we know that vitamin D deficiency is so prevalent in our society. So we know that it's the most common nutritional deficiency. It is found in huge number of cases. And in fact, the burden is huge. If you look at it, it causes neonatal hypocalcemia, it causes low bone disease, it causes low peak bone mass, infantile cardiomyopathy, and this is something which needs to be corrected definitely in this situation. Now, if you look at the overall burden, India has got a huge number of vitamin D deficiency despite the fact that we live in an area which has got good amount of sunlight. And why is that happening? The reasons are probably because this 24-hydroxylase enzyme seems to be hyperactive in our population, resulting in more inactivation of vitamin D. And secondly, greater intake of vegetables which contain phytates, which will basically block this calcium absorption, causing secondary hyperparathyroidism, will also cause increased metabolism of vitamin D. Plus the sun exposure has gone down, and that really explains. So the lack of sun, the increased activity of the inactivating enzyme, the increased intake of phytates may explain why we have this figure of around 60 to 80% with regards to vitamin D deficiency in different perspective. Now, if we really look into our own data, we see the figures around 50 to 90%. And if we talk about specific populations where sun exposure is less, it goes up to 90%. And therefore, there is a huge risk which is already there in our population. Imagine if we are already there in sitting on the edge, and this lockdown is going to throw us out. Our vitamin D levels are going to be really, really low in that situation. The next step, of course, is how do we assess vitamin D? And we've discussed in detail that the only and the best marker of vitamin D assessment is 25-hydroxyl vitamin D, which is basically independent to the levels of PTH, to the level of 1-alpha hydroxylase. It's basically a direct marker of nutritional status. But what really is vitamin D deficiency is a debate, and a lot of people get into that. Now, first things first, I'll say, do not think that everybody who comes to you and you want to give them vitamin D, you want to measure vitamin D. Now, we all know that 70 to 80% are deficient. So if you are giving a reasonably maintenance dose of vitamin D, you don't need to measure it because it's an expensive investigation. But if you want to do, then better would be to actually measure in that perspective. Now, how do you define vitamin D deficiency? Is itself a big issue. Now, the definition of vitamin D deficiency will vary depending upon whether you are concerned about hypocalcemia, which is the most severe effect, rickets, increase in ALP, or hypercalcemia. So there are different vitamin D levels which are associated with different responses which will happen. Now, somebody would say, I definitely don't want hypercalcemia to happen. So it's been shown that ALP levels tend to increase once the vitamin D level go below 20 nanogram per ml. And that's why a lot of people talk about 20 as a figure. And once the levels go beyond 100 nanogram per ml, the hypercalcemia starts. So probably the toxicity range is around 100, but is 20 really low? If you are really concerned about the toxic levels, of course, levels are more than 100. If we talk about 20 to 100, that is considered to be normal. Now, rickets typically happens if the level go below 15, and some people will actually say 12, which is considered to be the insufficiency range. And hypocalcemia typically happens once the levels are less than 5, which is extreme deficiency. So now, if you look into this picture, I would take probably the ALP as a cutoff because it means that already there is this bone resorption happening. Bone is being used. So better to maintain vitamin D level above 20. And these are the AAP criteria. The Endocrine Society talked a bit more. They talked about insufficiency of 20 and deficiency of 20 and insufficiency of 30. So the key issue is that vitamin D levels may be variable, but 20 and 30 seem to be a reasonable level to target in that perspective. So now we've discussed about the pathophysiology of vitamin D. We've discussed about how to assess what is the burden. The next issue is there any relationship of vitamin D and COVID-19. So of course, we are at a very, very early stage with regards to the research of COVID-19. We don't know much as to how it has come out, whether it has come out from the animal markets in China or some virology labs. Even that is not known. We don't know what its outcome is. So there's so many factors which are coming out of it. So all the evidence that we are talking about is purely speculative at the moment. And the big issue, of course, is that we are now faced with a situation that we have got so much time, which we never had. So what to do and how can we really improvise our musculoskeletal health, so to speak, because that's the first aspect to look at. So of course, being more physically active, getting as much sun exposure is there, and definitely keeping our bones strong. And it's now very, very clear to know, and that's besides this topic, that if you want to build your peak bone mass or your children's peak bone mass or your patient's peak bone mass, the most important thing is actually physical exercise. Genetics will determine 60 to 70% of the entire peak bone mass. You can't change a huge amount of it. 10 to 15% can be changed by physical activity. So 30 minutes, 45 minutes of physical activity, and 5 to 7% by vitamin D and calcium. So all this is important, and definitely between 10 to 18 years, vitamin D becomes extremely important in that situation. Now, there are some suggestions that vitamin D supplementation could theoretically improve the risk of influenza and COVID-19 infections and deaths. These are based upon some previous studies which have talked about how vitamin D plays a role in immunity, plays a role in terms of reducing the morbidity because of respiratory infection. But again, these are very early days. I would not say that vitamin D is, of course, a treatment for it. But of course, if your vitamin D is good and it helps, it's good enough in that perspective. So if you're talking about zinc, if you're talking about vitamin C, maybe vitamin D is also something which is going to help immunity in one perspective or the other. The other interesting observation which was really published, and this was something which was interesting epidemiological correlation, was that if we look at the latitude of a particular country and we look about the deaths which are reported with regards to COVID-19, and this latitude was also taken up as a surrogate marker of vitamin D deficiency, the increase in latitude meant more mortality. Now, this is again a very pure epidemiological study, epidemiological data, but we need to watch the space. So I think the message is you have to build your bones, whether you are bothered whether it's going to change your response to COVID-19 or not, but definitely ensure that your bones are good. So maintain your vitamin D, and maybe as a bonus, you may have a better response in that perspective. The other question which comes to the mind is how do we achieve that? How do we prevent it? And if there are problems, how do we treat that? Now, there are wonderful guidelines which are there. Just a few words about the vitamin D preparation, and we discussed in detail that there are active preparations like calcitriol, which are not bound, which are 10 times less bound to the vitamin D binding protein. They therefore have a very short half-life, severe effects. So they are more in treatment of acute hypocalcemia. They will cause hypercalcemia if you treat well. So calcitriol and 1-alpha-hydroxyvitamin D have no role in routine prevention or treatment of chronic vitamin D deficiency. They're only indicated for acute cases, so to speak. Now, vitamin D basically is the preparation that we have been talking about, and polycalciferol as compared to ergocalciferol we have discussed has got a higher D binding. It stays there in the system for a longer time, causes a greater rise. Very importantly, there is no role of parenteral vitamin D, which is there in this situation. Now, there are different guidelines which are available, and all of you should really go towards the Indian Academy of Pediatrics guidelines, which is really nicely summarized the recommendations with regards to vitamin D. In general, we are pretty much talking about the need of vitamin D of minimum 400 international units per day to 600 international units per day. So pretty much we need vitamin D across board, particularly for the first 1 year of life. And I would say between 10 to 18 years, because that's the peak time when the bone is being formed. We need to remember that there is a huge window of therapeutic window which is there, which is up to around 3 to 5 times. So you can give a slightly higher dose also and be safe, but do not give parenteral injections because that can cause a problem. Do not really go ahead with regards to the use of these active preparations. They will cause severe hypercalcemia. Now, if you just go on to the treatment part, basically the recommendations are daily therapy, but then the issues of compliance and other factors really come into that picture. And then there is a talk about this weekly therapy, which all of us have been using for quite some time in this situation, with regards to the use of around the daily therapy which we have been using with regards to, in this situation, of around 60,000 international units every weekly for 6 weekly. And this toss therapy is also recommended. But pretty much if somebody has got good compliance, I would prefer that we use a daily therapy in this situation. Now, very important to remember that the only role of vitamin D is to act like a calcium provider. So if you don't take any calcium, the vitamin D is not going to help. So always give calcium along with vitamin D, particularly while giving these large doses. If you do not give calcium, all your calcium will go into the bones, and that will result in the development of hypocalcemia and what is known as the hungry bone syndrome. So every child whom you're treating with vitamin D, also give them calcium in this situation. Now, there is a very wonderful document which is also available in Hormone Research in Pediatrics, which talks about the global recommendation for nutritional rickets. The recommendations are pretty similar. They talk about daily doses for 90 days, 2,000, 2,000, and once they go beyond 12 months, they're about 3,000 to 6,000. And they also talk about a single shot dose of 50,000 in the first year, and then 1.5 lakh and 3 lakhs, followed by maintenance. So they are pretty similar to what the IAP guidelines are. The Endocrine Society guidelines are a bit more aggressive. So they talk about a dose which can go up to 1,000 international units in the initial phase. And then they talk about weekly doses and a stoss dose. So pretty much if you want to follow protocol, follow any protocol, but stick to it. Give at least 400 to 600 international units daily. If you want to treat, best would be to maybe give around 2 to 5,000 to 10,000 depending upon the daily requirements, and you can give a weekly dose as well, which is quite effective in this perspective. So if you just want to summarize, for below 1 year, the preventive dose is around 400, treatment is around 2,000, upper limit is 2,000, 1 to 18 years 600, you can go up to 3,000 in that situation. And special circumstances, very important to remember, that individuals who are obese, who have got anti-epileptic therapy going on, these patients will require a higher dose of vitamin D in this perspective, at least double the requirement in this situation. So infants, adolescents, and those who have obesity, anti-epileptic drugs, and malabsorption require a higher dose. The only indication of an injectable vitamin D would be somebody who has a proven malabsorption like celiac disease in that perspective. Now, we know that there are so many preparations which are available. There are so many modalities. So what is good enough? And a lot of people say, okay, it's very difficult to give a daily this thing. So now we've got evidence which has shown that if we give monthly dose of 60,000 international units for a year, it is associated with substantial improvement in vitamin D level, which is sustained with no risk of hypercalcemia. So if you are too much bothered about compliance or adherence, 60,000 units a month in this age group would be pretty okay. Now, one big issue, which probably is a cause of concern, is that vitamin D is a compound which is associated with variability. So people have studied, and this was a study from Dr. Khadgawa that AIMS, which looked at the cholecalciferol content in different preparations, and they found that vast majority of these preparations that we get commercially do not have a reasonable amount of vitamin D. And if we add to this variability, the problems with regards to the absorption, particularly of the granules which have been traditionally available with regards to fat, this also causes the issue of bioavailability. So there is the issue of variability and bioavailability, emphasizing that the preparation of vitamin D that we choose is also important. And in this regards, there are now evidence which is emerging, and this is the gold standard paper from Dr. Marvaha, which looked into the miscellarized vitamin D supplementation, and which found that it was associated with a greater absorption, and it was fat independent as well. And this is something which is important. So we need to stick to a preparation which is good and which is getting absorbed better in that situation. So if we just want to now conclude the overall picture, vitamin D deficiency is reasonably common in Indian perspective, from 60 to 90%. It is going to be exacerbated by the lockdown. So all of us should take care of not only our own vitamin D levels, but our children, our parents, elderly, everybody, as well as advice to our patients, so that they at least have 60,000 units a month will be good enough for most of us in this situation. Very importantly, it may probably have a role in immunomodulation. So while we may think of vitamin C, we may think of zinc, and some will think of hydroxychloroquine. we may also think of vitamin D as something which is good for both bones, and maybe there may be some role there. And it may have a better rise of macronized vitamin D. And I think I'd like to close at that point of time and open up for any questions which are there in this situation.
Thank you so much, sir, for excellent talk. That was a very lucid talk on vitamin D and also in the times of COVID-19. Sir, we have a few questions, so we'll start with the Q&A session.
Yeah.
So we have one question on vitamin D3 and immunity. The question is, does vitamin D3 have immunomodulatory effects, and how that will be useful in COVID-19?
Yes, so the basis of this is built upon large number of epidemiological data, some basic research data, and also the evidences that were there. So we all know that there are specific vitamin D producing enzymes, the 1-alpha hydroxylase and the vitamin D receptor, which are expressed in a number of these immune system cells, particularly the macrophages, some of these lymphocytes, and they may cause immune modulation, which may happen. Now, there are some evidences that the risk of infections and the severity of infections are more if there's vitamin D deficiency. But all these, while we are talking about all that, we also need to emphasize that they are more of a association studies. So we cannot at the moment say, like, as we can say that vitamin D deficiency causes rickets, we will not be able to say that vitamin D deficiency causes immune deficiency or immune dysregulation. But yes, immunomodulation is a strong aspect of vitamin D deficiency. We know, and for us, particularly for pediatric endocrinologists, we know the associations with type 1 diabetes, we know associations with other immune diseases. So there is a role, but please do not jump that it is actually a one-to-one causative role in that situation.
Thank you so much, sir. Yes, sir. We understand that there is no still definitive evidence. So next question, can we increase the dose of vitamin D as we are in lockdown and the sun exposure is not that great, or you can say it's minimal?
Yeah.
What is your opinion on this?
Yeah, I think definitely if we talk about the doses, and as we saw that paper which talked about once a month dose being good, there are other papers which say in India that probably once a month is not good enough. Maybe once in 15 days is good enough, particularly for people who are dwelling with low calcium intake. So I would say from a reasonable perspective, if you talk about the safety purview overall, 60,000 monthly is absolutely the minimum that we should have, at least in this moment. And maybe we can think of every fortnightly. That will be quite safe in that perspective. If somebody has clinical features of tetany, spasm, leg pain, cramps, and all these, most cases come out of that, maybe we can think of more frequent dosing. But once a 15 days would be a reasonable one. If you've not been taking vitamin D for a long time, once in a month will be the basic, I would say.
Okay, sir. Thank you, sir. Next question is, what dosage should be given to 1 year undernourished baby who has not taken vitamin D before?
Okay, so that's a good question. So I think what we need to understand is that there are two ways of looking at it. And if we look into that perspective of, I'll just shut this chat part so it becomes clearer, I think. Yeah. So these are basically the guidelines which are there with regards to the IAP. And now if we talk about a 1 year, we are probably talking about preventive doses of 600. But if he's coming for the first time and you have a strong feature that he seems to be deficient, maybe you can start around 3,000 international units daily. So that sort of a thing you can go ahead, but at least 2,000 will be a reasonable dose if you're thinking of deficiency, and minimum 600 to 1,000 if you not think of a severe deficiency, if there is no features of rickets in that situation.
Sir, next question is, what is your take on giving 160K dose every 3 months to children more than 1 year to meet the needs as prophylaxis, as a prevention?
I think again, a lot of evidences are now coming up that probably giving every 3 months may not be enough. Now, of course, we need to probably classify 1 to 18 is not a homogeneous figure. The weight will be so hugely variable. So I would say above 5 years or 6 years, maybe once a month will be reasonable. We need to have more evidence between 1 to 5 years. I think that needs to be segregated. But overall, I would say giving once a month will be fine. Once in 3 months may be too little. And there are studies, especially for adolescent girls, that once in month may not also be useful. And they would say once in 15 days is what is required.
Okay. Thank you, sir. Sir, next question is on how long supplementation of vitamin D should be continued for a newborn?
Yes. So I think the I would say that the three most important areas in which supplementation is absolutely essential is during infancy, because to prevent neonatal hypocalcemia, to prevent cardiomyopathy, and because the maximum bone growth happens in the first 1 year. So I would say 1 year is the minimum. Then from 10 to 18 years, because 40% of the adult bone mass is achieved in that time. And as I said, 60% of it is because of genetics, maybe 7 to 8% because of vitamin D. So if you are able to get that much, even that is good enough. If you increase your peak bone mass by 10%, the risk of fracture goes down by 50%. So if you are actually getting good vitamin D, you may reduce the fracture risk by around 50 to 100%. So 10 to 18 years, definitely. 0 to 1 year, definitely. Pregnant women, definitely. Now, what about this 1 to 10 years? That is an issue. So if you are able to get this vitamin D reasonable, you don't need to supplement. If you are in a doubt, maybe giving that dose is not bad enough. But 1 year, I would say, will be the good to ensure that there is a good bone development. There is no hypocalcemia happening. There is no cardiomyopathy happening.
Thank you, sir. Another question related to this question only. So how to supplement calcium along with vitamin D in newborns and as the age group you have told just now?
Yeah, so generally, if we talk about the newborn period, the amount of calcium which is there in the breast milk is pretty good. So we don't need to really supplement calcium in most of those cases. Only if we talk about some premature infants who require a very high dose of calcium and phosphorus, we need to supplement. But otherwise, breast milk is very good as far as calcium is concerned. For the older age group, of course, we can use the calcium supplements, but these supplements will cause more of constipation. So generally the problem, if somebody is more on milk feeding, whether it is breast milk or cow's milk, the problem is not that much in that perspective of calcium. It is more of vitamin D in this situation.
Okay, sir. Thank you, sir. Sir, another question is on the doses. Which is better, parenteral vitamin D or oral vitamin D?
Definitely, there is no advantage of parenteral vitamin D over the oral vitamin D. And if you give a high dose of vitamin D, what will happen is that your levels will go up. Your binding capacity of the debinding protein is limited. So a lot of it will go into the urine. So your level will go up, it will come down. But if you give oral, your level will not go that high. It will keep stable for a longer time. So if you talk about healing, if you talk about long-term vitamin D level, if you talk about the vitamin D which is stored in the fat, it is the oral which is better. The only indication in which I would be thinking of a parental is somebody like celiac disease, somebody who has a malabsorption, gut resection, all those things. But otherwise, there is no role of parental vitamin D. And the major cases that I've seen with regards to hypercalcemia are either because of somebody is on a parental vitamin D, or if somebody has given low calcitriol. Cholecalciferol orally will not cause this toxicity unless you're taking a sachet daily for so many days, 20 days or something. So definitely stick to the oral, it is good enough.
Thank you, sir. Another question is, for a pure vegetarian, it's extremely difficult to get adequate vitamin D. Would you by default recommend supplements for lifetime?
Even if somebody is non-vegetarian, the amount of vitamin D you will get from the food is very, very limited, unless you're eating maybe 2 kgs or something like that of that. So probably, I think, without putting a bar about vegetarian, non-vegetarian here, if you have a good sun exposure, you are there 10 to 3, maybe you are a cricketer, you're playing in the field 10 to 3, maybe 1 hour a day, you don't need it. Otherwise, pretty much everybody else needs it, because in our population, the deficiency is around 80%, which is there.
Thank you so much, sir. Another question, what are the indications to test vitamin D level after we treat the deficiency? When would you suspect vitamin D intoxication?
Yes, so I would say the first question, the second question is more important, that we need to be very, very bothered about vitamin D toxicity. The key features of vitamin D toxicity are basically mediated by hypercalcemia. So if you have a child who comes to you with irritability, dehydration, polyuria, abdominal pain, after getting vitamin D, this is a sure short sign of vitamin D intoxication. Get a vitamin D level done, get a calcium level done, get a phosphorus level done, and you will evaluate for that. Now, whether we need to do a routine vitamin D every time on follow-up is a debatable issue. It's a expense related issue. It's an issue of doing an invasive test. So if you're thinking of really looking in response, so if you had presented with rickets, do a repeat X-ray after 6 weeks of therapy. If you're really bothered, maybe 6 to 8 weeks will be a reasonable time to do a vitamin D level because of the half-life, but I would not be doing in everybody.
Thank you, sir. Another question, from Dr. Nagesh, Bangalore. Anything wrong in taking vitamin D lifelong, 60K per month? Is it necessary to take oral calcium when you are taking once a month, presuming dietary intake is adequate? This refers mostly to adults and adolescents. And also another question, role of regular oral magnesium in the vitamin D.
Okay, now let's go one by one. So I think once a month is a pretty good dose. We can take it very, very safely. Nothing to worry about that. So I won't be bothered about that. We can take it. Regarding calcium, if we are taking enough calcium, 1300 milligrams per day, and maybe adolescents going up to 1000 to 1500, we would be okay with that. So if somebody is taking that much calcium, no need to supplement. But if it's less, take some calcium, maybe reasonable on that. I am not a big fan of magnesium per se. Magnesium deficiency is not very common and it's there in pretty much all the things that we eat. It has got magnesium. Magnesium deficiency basically happens because of the renal excretion. So if there is a problem of renal excretion, there's a diuretics, hypokalemia, all those things, malnutrition. So in those conditions, magnesium is important, but I won't say that magnesium is absolutely essential in those preparations. Calcium is, and that's the most important.
Yes, sir. Even if we see the evidences, Indians don't have magnesium deficiency as such. Thank you so much, sir. Next question. Most calcium supplements have additional vitamin D. How do you adjust this?
You forget about that. The amount of vitamin D which is there is negligible. It is not absorbed well. So let's take it out of the equation. Then we don't need to correct it for it.
Next question is interesting, sir. India have so much sunlight, then why vitamin D deficiency?
Yeah, so that I would say I would put it at three levels. First, we have got so much sunlight, but we are not going to the sunlight. Now, if you talk as my own lifestyle as a doctor or your lifestyle as a doctor, or let's talk about a lot of people around us, we hardly are going out between 10 to 3 a.m. for 1 hour every day. So that's one issue. The second issue, of course, as I discussed, was that we tend to have a greater prevalence of increased 24 hydroxylase action, which inactivates 25 hydroxyvitamin D to 24, 25 dihydroxyvitamin D. And the third important thing to remember is that we take a lot of vegetables which have got more phytates, which binds this calcium, triggers hyperparathyroidism, causing further inactivation. So all these three, and I would say first will be the most important because we don't go out in sunlight that much. Second, 24 hydroxylase deficiency, and third, intake of phytate containing foods will be the major factors.
Thank you, sir. Another question. Best age to start vitamin D supplementation to prevent rickets.
Okay, so basically we need to understand that there are three reasons why we are giving vitamin D. We want to first of all prevent neonatal hypocalcemia. This is the most important. This typically happens beyond 3 to 4 weeks of life. Second is to prevent cardiomyopathy, and third is to prevent rickets. So I would not be concerned about the rickets to begin with, but I'll be concerned about neonatal hypocalcemia, which will happen anywhere between 3 to 6 weeks of life. So start right at the time of birth because many of the mothers are vitamin D deficient. So for that, you start it right at the time. Now, most cases of nutritional rickets will present typically around 1 year of age. So if you actually are able to take care of vitamin D by then, it should be fine.
Thank you, sir. Another question is related to this only. So should we check vitamin D levels antenatally in mothers?
Yes, so if you go by any of those guidelines, they would definitely say that you check vitamin D level and give the vitamin D to the mother accordingly. But if you are not able to check, give vitamin D. After the first trimester, vitamin D should be given to all mothers. And I would say once a week, 60,000 is a reasonable dose to give in that situation because the requirement of vitamin D goes up. If you talk about fetal physiology, the fetus is a parasite. It is taking calcium out of the mother. And unless the mother has enough calcium, you can't take it out. So you need more calcitriol in the mother, and for that, vitamin D is required. So definitely 60,000 once a week is good enough from 4th month of pregnancy.
Thank you, sir. Next question is, I have seen few cases where even after vitamin D supplementation, the vitamin D levels never came up. Is it due to the slides you mentioned about differential absorption?
Yes, so
due to current formulations?
It could be malabsorption, which is there. It could be calcium deficiency. If you have calcium deficiency, your vitamin D will be inactivated a lot. So those levels may not come up. Third would be the preparations, whether these preparations are different. and how much are they really containing, and then the bioavailability. So a lot of these factors will take basically, there's a lot which takes from the sip of vitamin D to the time it reaches your body in that situation.
Okay. So another question, this is related to toxicity. If you reach level of 100, then how many months would it take to reach the normal level?
See, typically the half-life of vitamin D is around 2 weeks. The biological half-life may be higher because it is stored in the fat. So it will at least take 2 to 3 months to really settle it down. Your major concern is not vitamin D level. Your major concern is calcium levels, which may rise maybe 2 to 3 weeks later on. So keep monitoring calcium. Ensure that the dairy product intake is restricted. If the calcium levels are going high, start giving prednisolone, 1 to 2 milligram per kg for 6 weeks, and that usually should take the trick.
Okay, sir. Uh, Another question. Uh, Alkaline phosphatase levels are high. Should we recommend for the testing of vitamin D in those cases?
Uh, okay, so if you talk about alkaline phosphatase, it is a marker of bone formation. So it basically levels tends to be high if your bone turnover is high. There are of course high if you have a liver disease. So first thing would be that if you have a liver disease, which is there, in this case the levels will be high. But suppose your ALP is high, first I would say look at rickets. If you have clinical or radiological evidence of rickets, don't waste your money. You can give vitamin D. If you want to confirm, vitamin D would be a good test to look into after excluding the liver and renal dysfunction.
Okay, great. Sir, another question. Is there a difference in nanotechnology vitamin D versus non-nanotechnology vitamin D?
Yes, and that's what we discussed, that there are clinical evidence which has clearly come out that nanotechnology vitamin D provides a more stable, a more sustained, and a vitamin D level which is independent of the fat intake. So these are the definite advantages that we talk about with the nanotechnology vitamin D as we discussed.
Thank you, sir. Sir, you have described beautifully about calcitriol and use of calcitriol. So there is another, the question is on similar lines, why calcitriol should not be used in routine?
Calcitriol should only be used in children who have got vitamin D deficiency and acute hypocalcemia. It has got a very short half-life. It is very potent. If you use it for a long time in routine practice, you will cause hypercalcemia, which will cause many more harm than good. So don't use calcitriol unless somebody comes to you with neonatal hypocalcemia and seizures. We use calcitriol for hypoparathyroidism, pseudohypoparathyroidism, vitamin D dependent rickets, hypomagnesemia rickets, but not for nutritional rickets.
Thank you, sir. Next question is on respiratory diseases, role of vitamin D3 in upper respiratory diseases.
Again, all this, so we focus mainly on the calcemic benefits because there's huge amount of evidence which is there. The evidence with regards to causation and in terms of efficacy in prevention is a bit less, but still there is evidence that it may have an improvement because of the innate immunity component. So I would not say that you start treating vitamin D because you want to decrease the URI in that perspective, but if your vitamin D is good, maybe you're doing better in that situation.
Thank you, sir. Similar questions on extraskeletal benefits. Vitamin D recommended for atopic dermatitis?
Yes. So that role is definitely, that's beyond just the calcemic role, and this probably has got because of the skin. We discussed about the various organs in which vitamin D is acting, and skin is one of them. There are definite evidence that high dose vitamin D and maybe non-calcemic analogs of vitamin D may play a role in treatment of severe atopic dermatitis, eczema, and many of the other ichthyotic conditions also as well. And this is something which is emerging. There's a very good paper which has come up from AIIMS about congenital ichthyosis in which vitamin D improves the outcome. So we have to understand that vitamin D is not just in the bones, it's in the immune system, it's in the hair, it's in the skin, it's in the myocardium. It's also working at the level of the adipocytes. So there's so many factors which are there, but we don't know at the moment whether that would be therapeutically helpful in that perspective.
Thank you, sir. One question from Dr. Mohammed. Sir, I am clinical pharmacist in Kurnool. I am suggesting my patients to take vitamin D along with spoon of coconut oil. Is it okay? As it is fat soluble.
Yes, yes. So that should be fine. It will be helpful in that perspective. So if you talk about the conventional sachet formation, they should be taken with either milk or a fat content. So coconut oil will be very good. For the nanotechnology based, it is not required.
Okay, thank you, sir. Should we do serum calcium, phosphorus, and ALP level every time in high risk groups, for example, obesity?
Yeah, so Dr. Preeti, we do understand that there is an issue with regards to vitamin D metabolism in obesity. We need to give more vitamin D, but if we look at our own data, which we have done in terms of their bone health, in terms of the calcium levels, the levels are lower than normal, but they are not in the hypocalcemic range. So I would not recommend that every obese child, we should measure all of them. We should ensure that they have got a higher than normal supplementation which is being given.
Thank you, sir. Next question is on hypothyroidism. Does it affect vitamin D absorption?
There are some studies which suggest that there may be an issue with regards to vitamin D absorption, but more issues are the direct effect of hypothyroidism on the bone disease, and that's why the requirement of vitamin D can be higher in that situation.
Next question, any role of vitamin D in prevention of heart attacks? In many cardiac center, it's routine to give vitamin D. And what should be the routine? So that is the next question. I think first we will answer on the heart attack and cardiac
Yes,
scenario.
so the only proven role of vitamin D effect on heart is in the form of cardiomyopathy, which we have seen in children, in newborns because of vitamin D deficiency. Now, what it means is that vitamin D plays a role in cardiac contractility. Now, I won't say there's a RCT level evidence or a grade 1 evidence to suggest that. So, while giving vitamin D is good in that situation, it is not clearly evidence based to that level.
Okay. So next question is on routine supplements in diabetes, type 1 and type 2 diabetes.
Yes, so we do give for type 1 and type 2 diabetes because we do identify a lot of them are actually having vitamin deficiency. The bone health is compromised in these individuals. We don't give it with the aim that this will correct their type 1 diabetes or this will correct their type 2 diabetes. But yes, bone health is very, very important in that perspective, and that's why the role is there for their treatment.
Great. Is there any effect of vitamin D deficiency in pregnancy outcomes?
Definitely. And there is, in fact, randomized studies which have shown that the use of vitamin D supplementation in mothers in Haryana was associated with increased head size, increased birth weight, and birth size in children. So we are not only preventing their hypocalcemia, we're also increasing their size and growth overall. So it's very, very good in that perspective.
Thank you so much, sir. Next question is very pertinent. Question is on which guidelines to follow. There are so many guidelines. Which latest and best guideline for treatment regimens of vitamin D we should be following? Indian consensus statement or global?
If you look at most of these guidelines, they are pretty much similar. There's hardly one or two differences which are there. So if you look at critically and you want to search for differences, you will find, but pretty much the concept is pretty similar. The best would be to go a daily therapy, give calcium along with that, and if required, you can give the weekly therapy. Doses maybe 50 or 60,000, something here and there. So I would say most are pretty much similar in terms of context. Whichever guidelines you want to use, you can follow, and IAP guidelines are pretty good in that perspective.
Thank you, sir. We have another question. Which one is better for neonate supplement, 400 IU of cholecalciferol or syrup which has calcium, phosphorus, and vitamin D? So basically the question is on
vitamin D is always important. We don't give too much importance to the vitamin D which is there with calcium. We're not sure about how much is being absorbed. So vitamin D has to be separate.
Okay. So then the related question was calcium and phosphorus. Should we be giving it the role of phosphorus in this?
So calcium and phosphorus are only recommended in the setting of prematurity. So if you have a premature child who has a risk of metabolic bone disease, should we be giving those calcium and phosphorus? Otherwise, if somebody is feeding normally, no routine supplementation is required. If somebody has got a metabolic bone disease of prematurity, in that case, we have to give calcium and phosphorus, not on a routine practice. Now, many of the patients that we talk about rickets will have a low phosphorus, and people will say, okay, we give them phosphorus. But what we need to understand that this hypophosphatemia is not because of phosphorus deficiency, it is because of secondary hyperparathyroidism. So if PTH is high, phosphorus goes down. So once you correct this calcium, once you correct this vitamin D, your pTH will come down and your phosphorus will be normal. So calcium carbonate, very simple, can be good enough. Calcium phosphorus is not going to really help you a lot in that perspective.
Okay, sir. So we are now taking a last question. So one more question has come. Is it wise to supplement vitamin D in patient with low 25D but high 125D and high urinary calcium loss?
That would be a very, very unusual situation to look into, because if you talk about vitamin D deficiency, you should have hypocalciuria. So if you have a low 25 OHD with hypercalciuria, there is some problem. You need to evaluate for some rarer forms of tubulopathies, and don't just keep on pushing vitamin D in that perspective.
Okay, sir. Sir, this would be our last question. Nano formulations generally may cause higher availability, thereby leading to toxications. Does nano vitamin D also cause toxicity?
See, what we need to understand is that if we give anything in excess, it will cause toxicity. There is no confusion about that. But if you use in an appropriate dose, it will not. There is a huge window of opportunity, a therapeutic window which is there. If you give it within that, it doesn't cause the toxicity. But of course, it will cause toxicity if you give 10 times the dose which is recommended. So you have to be careful, and it will be very safe from that situation.
Thank you so much, sir, for giving beautiful answers and answering all our queries from our participants. Sir, do you have any closing remarks?
No, I think the closing remarks will be for everybody to stay safe, stay healthy, stay indoors, take care of them, their family, their children, as well as the patients. And we hope that we all come out of all this problem in a very positive fashion. And that would be the message. And I think keep taking vitamin D regularly. That will be the other message I like to give.
Thank you so much, sir. This was a beautiful talk. You covered very well on the different aspects of vitamin D and also touching upon the recent COVID-19 situation and also answering all the questions. Thank you so much. I would also